Ashwin Mallipatna from Sick Kids Toronto, and his discussant would be Raksha Rao from Narayan Nethralaya, Bangalore, talking on staging and classification of retinoblastoma. Ashwin, you can begin.
So you muted, sir.
Sorry, I was muted. Thank you very much for inviting me, and my talk is on staging and classification of retinoblastoma, whether it's apples and oranges or is it all the same thing. The traditional current staging system that we're all accustomed to is the ABCDE, where A are the smaller tumors, B are those that are more larger or more central, and C are the ones with focal seeds or subretinal fluid, and diffuse are the ones with, D are the ones with diffuse seeds, and E are the ones that are eventually unsalvageable or destroyed in some way or considered dangerous. This was the way that we learned staging in 2005 when Dr. Honawar had his the meeting in India. The ISO was held in India, and we were all introduced to this at that time. We were all in the handouts also guided towards enucleation of group E eyes. So later on, many years later, when I started to see that some group E eyes were being salvaged, I started to question which kind of group E could be salvaged in some way, and started to learn that there may be an entirely different definition of group E from what I was accustomed to at that time. And that came as a bit of a revelation to me, certainly I was not alone in that. And there was a paper published by the group in New York that compared the two versions of ABCDE, and we know that the Los Angeles version has differences to the ones that were guided by Philadelphia. And the main difference there was the fact that any tumor that's occupying more than 50% of the globe was considered to be a group E, and not so in the Los Angeles group. Does that make a difference? Will that make a difference clinically? We do know that some of the publications in a way try and adopt both methods, although they say that the publication uses ICRB and group EI by definition. We do know that half the definition could be taken from one and components of the other added to that as well. If you look at a retrospective review of intraarterial chemotherapy, that also mentions the salvage rates according to the classification from A to E, but it doesn't mention the different classification systems that are used in each of these papers. Therefore, some of these, and some of them, of course, not even mentioning which one of those two they've used. And some of them we're presuming based on what they have written in their text. Just anecdotally looking at this in using unilateral eyes that were primarily enucleated, we can see that these different definitions, if you take only 50% as the differentiating factor between an EI and a DI, we can see that the proportions of high-risk pathology that are reported in these studies, all from North America, are different, and maybe that can be explained by the fact that we're accounting size in some systems and not accounting for it in others. So how does all this matter? Does it really matter what we call these things? I just want to break the pace here and go to an anecdote that will maybe elicit how it's important when we call something something that we're not used to being called that. This is very familiar to all of us, and when I was in India, it was being called Hawaii chappals, but in Canada it was being called flip-flops. So I was familiar with both. Then when I went to Australia, I did not, for the beginning bits, know that these were called thongs. So when someone actually told me not to wear thongs to the driving test, it was a bit of a surprise, and I was wondering why I would need that kind of an instruction. So it does matter about what you're thinking about, and when you call something a thing and it's not really what you think it is, then we are talking about apples and oranges, and we're not talking about the same thing over there. To try and solve that, we thought of maybe rejigging a system at some point that could be used by everyone. And this was the group of people who've gone ahead and brought some consensus, and through the AJCC and through the work of Paul Finger and the rest of us in that team, we brought forward maybe an evidence-based classification, evidence-based staging system by which we can discuss different types of retinoblastomas that present to us. So the essential questions that we had were, can we generate an updated definition of what advanced intraocular disease would mean, and which group D or E is really associated with high-risk pathology, which eyes fail salvage therapy, and should we really enucleate some of these upfront? We did not consider older systems such as the Reese-Ellsworth classification, which had the size of tumor described in disc diameters, and whether there were single or multiple tumors, and whether the entire anterior extent of the tumor was not considered in this system as individual risk factors. So right now the AJCC is at its 8th edition, and currently is the only evidence-based staging system for retinoblastoma. We looked at peer-reviewed literature. We looked at a survey of about 2,800 eyes from about 2,000 children with retinoblastoma from all around the world. And we came across deliberations and consensus, which were not easy in any way. The principles itself of the AJCC system is that it has to conform to anatomical stages, therefore sometimes referred to as a surgical classification. And each stage would represent a progression in the anatomical extent of the disease. And there were quite strict instructions on how many categories you can have, and the diagnostic imaging techniques that you can propose, and those sorts of things to actually come to the final stage of each child at diagnosis. So very broadly, we're looking at a tumor in a very stage-wise progression right now, which is an intraretinal tumor goes on to fill in the eyes with either a detachment or vitreous seeds, and goes on to then progress further into CT3 eyes, which are advanced intraocular, which are those that we would consider E eyes mostly, and then from there spread to the extraocular sites. So that progression was maintained, and there are subcategories, of course, that some people do find confusing, but it does have a method, and it's easy to learn when you've gone through this system multiple times over many weeks. So just to break it down a little bit, T0 is when an eye has, or this is only the clinical staging system, where T0 is an eye which has no tumor. T1A is a small tumor or something that's, and if a small tumor is closer to a disc, it's T1B. And if it's even a larger tumor, then it could be a T1B or even closer to the macula. T2A is where you start to have retinal detachment, an exudative detachment. And T2B are the ones that you start to have either subretinal or vitreous seeds. And T3s are those that we would consider the eye unsalvageable in some way, such as with hemorrhages or anterior segment involvement, or a cataract or buphthalmos or glaucoma or any of the others. And we actually broke it down with A to E, with what we thought at that time was the ones that correlate with least with high risk pathology on top, and the one that correlate most with high risk pathology below. So there is some sort of an hierarchy there. And I must specify that tumor invasion is required for T3B. Previous to this, it was only considered that tumor touching a lens would still be an anterior segment invasion, but we don't. We tried to make that distinction clear by saying that there should be some evidence of invasion, not only contact. There is T4A, where you have radiological evidence that the tumor might have left the eyeball, and T4B, where you have overt extraocular involvement, where the tumor has maybe even clinically has evidence of having left the eyeball. With the TNM system, we do have nodes where N1 would be the involvement of lymph nodes, and M1 would be the involvement of distant metastatic sites, M1A and B distinguishing CNS and distant sites. We do use prefixes as well. C is for clinical, P is for pathological, and the prefix of Y would tell you that treatment was provided prior to this staging when you're trying to restage a child. And with the pathological classification, we tried to maintain a similar stage-wise approach. It was a little bit harder, where PT1 was tumor without local invasion, PT2 was only local invasion, PT3 was significant local invasion, and PT4 would be extraocular. And of course, we also had the pathological proof of metastasis, which was A and B, with the hematogenous and central nervous system being involved. The pathological staging system, again, when it's described, is PT1 is when it's in the eye, PT2 is when there's focal involvement, or PT2B could be the ones with involvement of Schlemm's canal, and PT3A is where you have choroidal involvement, which is massive, and PT3B is retrolaminar choroidal involvement. PT4 is where the tumors left the eye. Okay, thank you. I'll quickly run through this. So what evidence do we have now? Thanks to Dr. Tomar and his statistical prowess, we've rejigged the evidence and recently published on the patient survival in each of these stages, which is listed here, as you can see, and it does go in a hierarchical manner, with the least survival being those with obviously extraocular disease, and group E eyes are what we used to call the CT3s over here. If you look at treatment failure as well, you can see the similar progression, where secondary enucleation is more common in those with CT3 eyes, and up to 56% of them were enucleated secondarily, or maybe even went on to get radiation between January 2001 and December 2013. And a similar progression with high-risk pathology in primary enucleation, where you have the highest risk in these eyes by the definition of CT3, that have a high-risk pathology there. I wanted to go through some case examples, but I think in the interest of time, I will run to the summary about why we should really bother. This is the only stage-wise progression system that we know of right now, which follows the natural history of the disease, and it better defines an eye that might be at risk to preserve. Therefore, CT3 we think is potentially unsafe. This also combines the IRC and ICRB in some way, and the staging of the IIRS as well, which is Dr. Shantada's staging system. And this moves away from the familiar but inconsistent group D or group E that we all talk about. And it's one system that's useful to ophthalmology, oncology, radiology, pathology, and genetics. And there are more reasons, such as the introduction of H1, which is very useful, and better defining what we would consider high risk, because it's not binary anymore, and there's actually a spectrum to this according to the staging system. So for anyone who's interested, there's a handout and they can download the presentation as well. With this, I thank everyone and I would like to stop for questions. Thank you.
Thank you so much, Ashwin. As usual, you covered it very exhaustively and very nice inputs. Raksha is the discussant. She's from Narayan Nethralaya Bank.
Yeah, thank you, Dr. Ashwin, for a very insightful talk. Examples that I've included in this presentation of mine, and I would like to discuss with you how would we incorporate that in the AJCC 8 system. So this particular case is that of a retinoblastoma group D, where the vitreous seed type is the cloud type, and it has taken a very long treatment process and a very long time to achieve a large amount of regression, as you see in the second picture here. So post IVC 6 cycles, the intravitreal topotecan 7 injections, and a combination therapy of topo and melphalan intravitreal injections of 5, and still ongoing focal therapy. There is still some tumor that is remaining, as opposed to a retinoblastoma group D, where the vitreous seeds are mostly spherical type and the main retinal tumor was almost the same size as the previous case. A large amount of regression was obtained just with intravenous chemotherapy of 6 cycles and intravitreal topotecan of just 2 injections, and you see that most of the vitreous seeds have been calcified. So based on this particular paper as well from the Abrahamson group et al., in their table as well, they mentioned that it is the cloud type of vitreous seeds which takes longer time to regress and which requires a higher median number of injections. As also in another table, they have described that the ocular survival rate of eyes with spheres is less than those as compared to cloud and dust type of vitreous seeds. So there's definitely a need for redefining group D on the basis of type of vitreous seeds. So how would you say that we would incorporate this in AJCC 8?
That's a good question. I think Ankit has published a paper on vitreous seeds and how that impacts ocular survival as well.
Okay.
I think our challenge at that time was that we had retrospective data up to 2013, and intravitreal chemotherapy was not quite heavily featured in those cases that came up there.
Okay.
So the group consensus that we had was that we wanted to simplify the seeding in some way, that we wanted to take away what we'd consider focal seeds and diffuse seeds, because we had at that time felt that with intravitreal chemotherapy at that point, which was already introduced, we thought that things would be very different from then forward. Therefore, taking away what we would consider focal to diffuse seeding. And maybe if there was evidence, yes, bring it back in some way or bring it differently. We did discuss with Francis Mounier at the same time, who's also an author in that chapter, about the different types of seeding, which is cloud, spheres, and dust, and whether we should incorporate that or not. The challenge there, of course, was how we would do it within the AJCC structure. Therefore, if we have seeds as a category that's not differentiating subretinal or vitreous seeds, then can you introduce a subcategory? So then it would become a 2B1 or a 2B2, and we were hesitant to make it more complicated in that way. In fact, we were even hesitant to separate subretinal seeds from vitreous seeds as well, although they have an anatomical distinction in some way for us during presentation. So yes, you can make further correlations from here. I would think we'd still want to keep the larger system less complicated, or as simple as possible in terms of representing globe salvage and representing survival. Because really for the AJCC, the primary objective was survival of the patient. And then obviously for us as ophthalmologists, eye survival is very, very important as well. So we were trying to incorporate both, but not get too complicated. That was the attempt. And yes, there is certainly going to be evidence that comes up in the future. We want to try and make sure that, if we stay as an anatomical progression in the system, then I do think that the subgroups might change a little bit, but the larger groups, which is T1, T2, T3, and T4, shouldn't change for the future.
That
editing.
is true. So you have mentioned my next example also, the group D with vitreous seeds versus group D with subretinal seeds. We have all noted that the exudative type of group D responds much better than an endophytic kind of a group D to both IVC and IAC. So probably this also will be included in AJCC, the smaller subdivisions.
I mean, we're not proposing anything within the structure of AJCC. I'm not sure if we're allowed to, and if I'm given the opportunity to do this over again the next time, then we'd see if the rules have changed a little bit. But for the time that we did this, it wasn't really. We couldn't accommodate that detail in it without losing, let's just say, the usability of the entire thing.
Sure. So again, group E, there are different high risk factors, a very diverse group which has preseptal cellulitis phthisis, which has obviously almost zero scope for ocular survival. However, like our recently published article on NVG, we noticed that certain eyes are definitely salvageable. So I know you have made a subdivision of A to E in the stage 4 of AJCC.
Stage 3.
Shouldn't this have stage 3? Sorry, yeah. So shouldn't this have been a little on the higher side NVG, since we know that some of the, and even Dr. Carol Shees also has published a paper where they have mentioned about an NVG case which was salvaged.
Yeah. So at the point at which we'd actually put that out, there was not that kind of a large series that we could rely on with that kind of evidence at that time. Any evidence that comes up, of course, will be considered for future editions. We would like to stay evidence-based with modifications as well. But that being said, if you look at it, we broke it down into subcategories instead of just calling it a group E, because before all of this would be lumped into a group EI, but we actually broke it down into subcategories because of this. We wanted people to actually go out and investigate the differences between these small groups. Absolutely. And then glaucoma would come under
3C, I think.
C is what I think, yes. Yeah. So if it's C, then you can tell us that C is in some way vastly different. And if it's peer reviewed and accepted by the panel, then I would hope that it gets included in future editions as a difference. Yes.
Okay, so this is the last set of slides. So this is the retinoblastoma group C, which has wonderfully responded to intravenous chemotherapy, and a very bad group D, which has responded wonderfully to IAC. So since we know that the international classification of retinoblastoma was invented at the time chemotherapy and post-chemotherapy, the response to chemotherapy, so should there be a definite a new staging system in the era of intravitreal and intraarterial chemotherapy?
So that's a good point again. I think that's why we've tried to stick to anatomical definitions. That's the reason why we didn't want to go into too much with the larger groups. With the subgroups, yes, you can go a little bit into which one might be better, which one might respond better in some way. But I think with the larger groups, it was important to stick to the natural history of the disease itself. And I think that's the strength in the AJCC staging system, is that it represents a stage-by-stage progression of disease. I think we managed that with the clinical staging, but it may be work in progress with the pathological staging system.
Yeah, Dr.